it's overwhelming because there are so many possible differences in the different groups that we have to deal with on a daily basis, particularly in America, which is at the same time the beauty of America. So I think that one thing that I've learned to feel comfortable with is that sometimes I'm going to be stepping on somebody's toes because I didn't know something about their culture. And it's not that I feel that it's right, but it's just a fact that we are not going to be able to always understand where this person is coming from. But we can make programs and we can try to bridge that gap and that difference. And at the same time, there are some universal values that everyone has. Let me give you an example. If you have a patient or a client with you and that person does this, what do you think that means?
It depends on what just happened before.
They're shocked.
They are shocked. It depends on what happened before, but it's a universal sign that something you said surprised this person. It could be in a way that made them embarrassed, or it could be just, you know, how can you be so bold, right? Or what about, someone that crosses their arms like this? What does that mean?
Probably not agreeing with anything you're saying.
Right. Right. And how about, or they could be bored. They are not there. You're not reaching them.
Passive aggressive.
I don't want to go there. How about that one? When they are fidgeting, they are nervous, anxious,
Or it could mean they're in a hurry.
or they are,
Are you
yeah.
done yet?
You know, doctors do that a lot. Doctors do that a lot, and I think that getting feedback from our fellow co-workers is very helpful in taking the time that the patient needs, and that some people need more than others. But these are, you know, some of these are universal signs that can give you a lot of information about what you are accomplishing or what you did not accomplish. That I think is important when culture it's different between you and one of your clients. So why is it important in health? It's important because when you try to send a message to the patient, either about their condition, their treatment, their prognosis, they are going to view that information and attach the meaning of that communication based on their values. That's how you understand what the doctor tried to tell you, or what the clinicians are trying to tell you. And they have a really hard time if they cannot put it in the context of their culture. But also, we have a hard time as providers if it doesn't fit our pattern. And for example, you're seeing someone, you're seeing a patient from another culture that is going through some significant changes in her private life, but she comes to you with an elevated blood sugar. And you go like, well, you know, you haven't been here for so long. You missed several appointments, and you start to get kind of upset with this patient that you call non-compliant. But you are ignorant of what else is going on, that perhaps that's what we need to be treating. And we are all only focusing on that HbA1c, or, you know, elevated blood sugar, whatever brought her to your immediate attention. So in her context of things that are happening, maybe she doesn't speak the language. And that has caused a number of other problems in her life that now she just can't focus on her medical needs. About cultural awareness. Well, the Institute of Medicine in 1999 came out with a report where they recognize not only that there were a lot of medical errors in the United States, but also the differences among the patients and the practitioners. Mm-hmm. And it included the fact that it was difficult for the physicians to accept that they had discriminatory attitudes. But they were ingrained, and we react to certain behaviors of our patients just based on the way we were raised and our own values. But this is not to a level that you are consciously doing one thing or another. Is more of an automatic reaction. And they stress on the importance of recognizing that you have your own cultural beliefs, values, or patterns of behavior, and that you shouldn't impose those on the patients. And it sounds easy, but it sounds right also, but it's not easy to do. Now, factors that can affect healthcare. I put language first because I thought that that's probably one of the most important ones. And we're going to go over and over today in our discussion. I'm sure that all of you in this room had been in the situation where someone was speaking another language that you didn't understand, and you're totally lost. And particularly in healthcare, you just cannot wing it. You know, like when you're out having fun or with your friends and you didn't understand something they said, you know, you can act like you did or whatever. But in healthcare, if there is not good communication between you and your patient, research shows, and common sense too, that the outcomes are not going to be optimal. Also, other elements that can affect our healthcare are family relationships and experiences. So you can have a patient that comes with a daughter, and the way she understands something is completely different to the way and the style of communication that the patient has. Particularly if they are coming from an underrepresented background, you can imagine a first generation versus a second generation in the same family, how their values are different. So one of them may be more aggressive and the other one a lot more accepting of whatever condition they have. Sex and gender. Well, sex and gender has been an issue for a long time, and I think that particularly with gender, it used to be that research in medicine was all about men. And that started to change in the 1990s when the women's health research started to develop, and to look also at the diseases that affect women and their outcomes. But before that, we could only relate to what the men and the research related to men was available, or maybe not only, but predominantly. It has dominated over the years. Also, sex is important because some diseases occur more often in men and others occur more often in women. Our spiritual beliefs and values. You know that some cultures, if someone is sick, they think that they did something wrong, and this is actually punishment for whatever they did that was wrong. And you can imagine, nobody's perfect, so we all have done something wrong. So there's plenty of reasons why any one of us can be sick under those conditions. But it's important to understand those values so that you can be effective in providing care for those patients. Have you encountered things like that in your practice? Right? So our challenge is how we can care for individuals from diverse cultures and with perspectives that are different from our own. And I think that I can narrow this, and our discussion is going to go through all these 4 different major topics. First of all, we have to recognize that there are some clinical differences based on race, ethnicity. For example, the black population has a higher risk of high blood pressure. White women tend to have more breast cancer than, is diagnosed more often. However, black women tend to die more often from breast cancer. And in this way, you can imagine some diseases that the way we learn in medical school is you see this, you associate it with something else. Also, another challenge that we mentioned already is communication. Particularly when you can imagine how more complex it is in the presence of a different language than the one that we dominate. So you can imagine if there is miscommunication between doctors. Imagine the miscommunication when you have a patient that wasn't that much educated and has a different language and now is sick. I mean, the problem gets so much complex. One of the things that I do in practice is I care for patients that are that are insured with the workers' compensation program. Well, if the workers' compensation program is complex to me, imagine to those patients. If something doesn't get done or they don't approve something, there are a number of steps and they are time sensitive that need to be done, and the patient has to initiate it. And let me tell you, we see sometimes catastrophic things happen because it was so difficult for them to follow what they needed to do to get the best outcomes. Also ethics, and to me, this was the best way to describe ethics is the respect for the belief system of others. And trust, either the fear of authoritative figures, that's the way that many patients visualize their physicians. And they are even afraid of telling you their symptoms and complaints. Or some of them know that they are going to see Dr. X next week, so this week they are really, really good with their diet. Like, you know, if they just see the doctor like this authoritative figure and they don't realize that it's about them. And of course, previous negative experiences, which we're going to be discussing. So one of the things that research has shown is that physicians are less likely to refer Black people and women than white men with identical complaints of chest pain to heart specialists for cardiac catheterization. And one of the explanations for this is that there are racial and sexual biases involved. So what things can you do to change the way we practice and make it more attractive to our patients? So some of it may be related to the environment, making it more welcoming. You know that some doctors' offices have fish tanks and, you know, things that just make you feel more comfortable coming to see your doctor or your clinician. Avoid stereotyping. Well, easy for me to say it. It is so difficult to do in practice, but you know, if you pay attention to these things, I'm sure that you can make a difference. Include community input for planning and development. And I think there's a group of people in UTMB that does a lot of the community research, community-based research. They're really good about including the community when they are planning and developing programs. There were some studies that show that in Hispanic women and Black women, having a group of them review the materials of scientific information or medical information that you wanted to convey to them was more effective in getting them involved and having better outcomes. For example, for a screening mammography, to increase the visits and their use of screening mammography. So educational material, educational approaches are things that we can do to help out, for example, what I was saying, people in the workers' compensation program, and to find ways for the community to take the lead. What else can we do? Be advocates of our patients. Understand that there is no recipe. It's not that you did this and you do that with everybody. We have patients that take more time. We have other patients, other families that are more complex. Understand risk factors so that we can address those differences. One that I think is very, very important is to hire staff that is representative of the population. There's something about coming from the same place that it's so difficult to explain. A few years ago, I happened to walk into one of my friends' home in Houston, and I walk into this girl that I met when I was in high school in my hometown. And it was so funny because I was telling her I had visited, and my daughter was at that time going to middle school, and I had told her how I visited some of the schools, and one of them was, you know, the one that I liked the most, and they had this auditorium that looked like Teatro Yagüez. And she laughed and laughed, thinking, you know, I understand perfectly what you meant. because we are from that same place. We know exactly what that meant. You know, it's this very old structure. There's a theater in our hometown, and she was like, I identify with you so well just because you said that. And of course, none of you would, because you don't know what it is, you know. So when you get to meet somebody from your own culture or that speaks your same language, there's some connection that is very special and beyond words. And then the message that I can transmit to that patient is so different than the message that somebody else that may even have more knowledge is perceived. So I think that this is one of the beauties of having diversity in our healthcare. And it's not that you need to have a doctor that is of your same culture, but having the interprofessional team being of diverse origins can very much help to get that message. And then understand the evolution of cultural competence and be creative in the way we communicate. Now, what barriers we can find to services or to access services that we provide may be from structural to cultural. In structural, we include health insurance, and of course, I think that speaks by itself. We all know that it can be very limiting. Also, having high out-of-the-pocket expenses is a deterrent. Any system, any healthcare system that has high out-of-the-pocket expenses, we know is not a very good healthcare system. People cannot access that. And an example is the Mexican healthcare system used to be very expensive. People had to pay a lot out of the pocket to get services, and that was one of the targets that they use in their healthcare reform, which is still going on, so that people wouldn't have to use out-of-the-pocket expenses to get their care. And it's a good way of measuring the success, for example, of a universal health system. Lack of transportation is one of the most common problems that patients report for not coming to doctor's visits or clinician visits. And there are many institutions that provide transportation for the patients. Another one is language. Again, it comes on and on. And cultural barriers had a lot to do with the styles of interaction and also expectations. Some cultures really don't expect a whole lot, and other cultures expect, all kinds of details. And the styles of interaction. Some people are more direct, other cultures are more indirect. Some people don't expect the physician to discuss end-of-life issues with their patient, and then others are the opposite. So these are just different communication styles. So why do we talk about this, and why is it important? Well, we talk about it because it's law. Because no person in the United States shall, on the ground of race, color, or national origin, be excluded from participation, denied the benefits of, or be subjected to discrimination under any program or activity receiving federal financial assistance. So in addition, it's law, so we should not be discriminating. Examples of health disparities. We know that Native Hawaiians have very poor health profile. African Americans compared to whites have 30% higher death rates from all cancers. Hispanics have doubled risk of diabetes mellitus than whites. So there are health disparities just based on race, ethnicity differences. And what can we do? What interventions can we do in a way that is culturally competent? Well, we can address racial identity. We can work on interrelationship among class, race, ethnicity, and gender. Try to work with low-income families, older adults, in a way that addresses their problems. Also use religion and spirituality to reach out. Be aware of gender identity and sexual orientation, immigration. Of course, someone coming to us that's an immigrant, that are going to have certain problems that people that are non-immigrants wouldn't have. If those immigrants are now acculturated, then the problems are different. If they have assimilated the culture, the problems are different. Other interventions, we can work with multicultural groups and families. Anybody has any ideas about how to do this? Work with multicultural groups and families.
Maybe like in community groups?
In the community groups.
Maybe understand some of the objectives of groups like LULA, what they do, or reaching out to their community and constituents.
Sometimes just in our own workplace and noticing how different people from different cultures do things differently, and if you're on a good enough relationship to say, well, why do you do that, or what does that mean, or I don't understand that. Something from as simple as foods for a holiday that you've never heard of before.
Mm-hmm. Working with people with disabilities. How can you do that in your practice? People with disabilities, if you want to connect with them, they even have their own newsletters. And you could use this type of avenues to convey messages about healthcare, changes in your practice, and things like that.
Become familiar with ADA requirements?
Yes.
Social work especially.
That's very difficult. Actually, I wanted to do some assessments of our facilities here in mammography, and I was not allowed to at this point. And I think that even though you may think that we have very accessible areas, when you start looking at it in detail, it's not as accessible as you thought. So we had, a couple of years ago, disabled researcher visited us, and we wanted to hire her and stay here at UTMB. And one of the things she said was that she went to one of the bathrooms and it wasn't wheelchair accessible. I mean, it seemed like it was, but it wasn't. She couldn't accommodate her wheelchair in it. And then they took her out for dinner, and she was expected to cross over the train, how do you call that, rails?
Tracks.
Train tracks, which is, in a wheelchair is no easy thing to do. And a number of little things that you wouldn't even think about, but when you are disabled, that's what makes the difference between being independent and not. So working with people with disabilities can be challenging. They empower your patients, community building, reaching out for populations of color. How can we do that? Reaching out for populations of color. Getting people that are from the same race in healthcare, increasing the number of people available that can relate in the same way. What other ways?
Would this be like when they were doing the program educating women about mammography in African American beauty shops?
Yeah.
Because that's such a big part of the culture.
That's beautiful. Really an interesting way to do this.
One of the things that our translational science grant committee did was identify role models in the community to bring them together to do some planning, and then ask them how they would intervene or work to access and inform each one of their populations or their group on the validity of what the research community was trying to do. Sort of as an intercessor, is that the right term? So finding ways from the people who were respected and looked up to from the community to tell us what we needed to do to access the local community.
That goes into, that ties in with what I was saying previously. That's how some of the educational materials that were more effective were created, is by bringing these populations and asking them, based on your culture, how would you teach this? How would you reach out to these people? And they come up with ideas that are more effective in conveying the message. And then ways of training, culture of competency based on models of practice. There are some models of practice that we will discuss. And basically being accepting, committing to your patients and your population, the population that you serve, is something that people understand. You know when somebody likes you, don't you? You know when somebody is committed. These are things that are more of, they are universal values. The empathy, when somebody is empathetic, which is not the same as sympathetic, right? Is that ability to perceive and communicate with sensitivity the feelings of the client and the meaning of those feelings. And genuine, when your doctor is genuine, that's something that nobody has to tell you. It's something that you can perceive, something that you know, that they were genuine, they told you this or that. You have to keep the openness, the spontaneity, congruence, and the opposite of phoniness, which we see some people in our own practices. Mm-hmm. And sometimes it's so hard to tell them, we're not going to go with this. That's not the way I'm going to do it. So culture of competence, those culture congruent behaviors that we were talking about. If you're genuine, if you're inclusive, it's the behaviors. It's not about telling people that we are culturally competent. It's just what you do and how you do it. Having the appreciation and the respect for differences and our core beliefs, the warmth, the empathy, the genuineness. Is it there? That's basically the values that will create an environment of cultural competence. The principles of cultural competence: values and attitudes. Be aware of attitudes and behaviors due to cultural differences. Be sensitive, understanding, and non-judgmental. Be flexible and skillful in adapting to different contexts and circumstances. So, let me give you an example. Remember when we were talking about that patient that came that had the high blood sugar and had some other problems in the background? So trying to understand what's happening is not going to be that easy, because sometimes people just don't tell you. But trying to work out a system with them might be helpful. And can you think of ways that someone, for example, that doesn't have a controlled blood sugar could be helped by us? What things you could do when you see this person to make him more compliant?
Would you ask them what's been going on in their life?
Yeah. Yeah. Perfect. Simple. And we can see them more often. We can ask to see them more often, because more frequent appointments might help with compliance. About side effects to medications. Have you ever had a side effect to a medication? And what did you do? You stopped taking it. Right? That jerk doesn't know that I cannot use this or that. It happened to me. I have this migraine headaches forever. And I went to a doctor, and I was having them very frequently, and he said, you need to start preventive medication. I mean, it was at that point. You really need it. It can't be PRN. It has to be something that you take to prevent them. My usual blood pressure is like 80 on 60. I mean, I have a really low blood pressure, and he started me on calcium channel blockers. I was like, boom, in bed. I mean, the treatment was worse than just not taking anything. So we have to be, very conscientious about who you're seeing, what they can have, what they cannot have. And I think, above all, flexible, skillful to adapt. Now, there are stages of cultural competence. When you see a patient from a different background than yours, understanding the cultural background. And I think that what I am seeing recently is to go beyond understanding and get to that step of being inclusive, accepting and inclusive. Acknowledge that there are differences in values, beliefs, and behaviors, that you cannot impose yours, and that I think is hard. And understand that cultural difference is not the same as cultural inferiority. Adapt optimal healthcare delivery to an acceptable cultural framework, because that's what's going to work for that patient. For example, the patients that will rather do alternative medicine, is that right? Is that wrong? And I think there's a belief that these products don't have side effects among the patients, right? And it's just, there's not enough research to begin with, and we don't know enough either. So on many occasions they are taking something, is it good, is it bad? Look into it, right? I mean, maybe some of these patients need this type of acceptance, that it's okay, and to be more understanding of what they are taking and their possible side effects. Can you think of something else? Adapting to the,
In terms of providing healthcare delivery.
and adapting your treatment to their cultural framework.
Maybe looking beyond stereotypes, the stereotypical idea of, like thinking about Italians in terms of that culture. For like just in terms of diet, in terms of what they would expect. You would expect an Italian to eat, for example, or any food.
Yeah.
And so, just communicating in terms of what their diet consists of, or how well do they, in terms of exercise, may not be something that they really value within that culture. Doesn't mean it's wrong.
I mean, exercise is a great example because I think we have plenty of evidence that it helps cardiovascular system, your blood pressure, it gives you a sense of well-being. It keeps your cells younger, right? There's research. Is it younger, the question? Yeah. You stay younger if you exercise. Plenty of evidence. And who wants to exercise? I mean, not very many people. Not very many people. Taking that message out is not simple. And I think we react to people that are obese, overly obese.
Well, if you really expand the idea of culture, a lot of times with therapy, I know that we struggle with families who there's abuse in the family, and so now you're trying to, your patient is the person who's been the abuser, for example, and now you're trying to do education with the spouse of that person. So now they're going to be the caregiver, but you have to understand why you're not getting through to them maybe initially, and then you come to find out the more questions you ask, if you even bother to ask them, that that person has been abusive to them throughout their whole marriage or perhaps their whole childhood, and now you're asking them to care for that person and to do different things for them. And so I think you're not going to have any effect whatsoever if you don't understand that in the beginning. And that's a difficult concept because most people aren't going to just be very forthright with that information. I think another example is people who have been alcoholics for years, I mean 30, 40, 50, 60 years, and you're trying to talk to them about safety in their home or independence, and understanding that their culture is, they're going to go back to that. There's just a lot of built-in support for that type of living and behavior, and just modifying, not being judgmental about that and not expecting them to change, but just modifying your approach so that it's kind of a win-win situation, the best situation it could be. And the other thing that comes to mind as a therapist, we have to go and work with TDC patients. And not just TDC, but patients on the inpatient side that maybe are federal inmates or something, and just the way you, first just your whole attitude and approach toward those patients, but then also understanding something that you might say to one person in the free world and what you might say to someone who you don't know exactly what they've ever done but got them into prison. but their whole belief system and value system is different. And as a therapist, and I'm sure it would be similar as a nurse or a social worker or a physician, you have to stop and take that into account before anything you say or anything you do is going to accomplish anything. And I think sometimes we're in such a hurry we don't even bother to do that.
I'm so glad that you brought that up. It's a really valid point. And it reminds me that I read the problems begin when we start to evaluate things as is fair or is not fair. We start bringing problems when we think, oh, but this guy, I mean, why would you bother? When we start to be judgmental, is it right or is it not right? And that's, we bring the problems along with us, because you can't reach out. So I'm really glad that you brought that up.
And to go even, that was really good that I brought out too, because you keep thinking in terms of culture, of ethnic differences. Well, there's rural and urban. There's a whole rural culture in terms of how they approach healthcare in a rural community, and how they may adapt, possibly because there's not maybe historically great access to healthcare. Maybe there's more reliance on home care, staying close to home remedies or whatever. So that whole culture, how that's taken, I would think that be addressed.
The other thing I think about is that those of us who work in healthcare, I think, completely lose sight of how much knowledge non-healthcare people have about healthcare. And so you explain things to them in a way that you think is simple, but they have nothing to do with doctors, maybe once a year, maybe not at all. And they do not know what you're talking about. And we have to be real careful about, I think, paying attention to what the general population knows about healthcare.
Have you ever had the experience of drawing them a simple figure of what you're trying to convey, and how, it changes everything all of a sudden? You took the time to try to put it in a figure for them. Even if it's simple, a circle and whatever. I find that it helps so much to make them understand, because they don't understand all this anatomy and all this physiology that we do.
One of the things we talk about is you're going to get on the interpretation. We think of it as language for culture. Doctor speaking in English, and you have a Hispanic or an Oriental. But medical is its own language, and it needs interpretation.
That's a good point. Good.
It's amazing what you find out when you ask the patient sometimes. Even children, they're a whole other ballgame, obviously, but we had doing a TNA on one time and brought him in, and I said, finally I just kind of looked at her and took time and said, what is it that's bothering you? Well, my brother told me you're going to cut me from here to here. I told her. She was scared to death.
Well, that was a wall.
Yeah. It's a good barrier to get rid of in a hurry.
Yeah, dangerous. Very good. Values and interpretation, the value of time. We face that one in the clinic a lot. Also, what we were mentioning, the doctors that go to see patients and they want to rush because they have so many other things to do. But valuing that time with the patient has a tremendous effect, particularly if you understand that you don't have to spend that much time. If you focus on them for a few minutes, you can get so much accomplished, and they give you that feedback. And somebody mentioned, the fidgeting and all that, and I just could see the doctors that are always like rushing. and how you can stop for a little bit and make such a difference.
Yeah, and for some cultures, time is non-existent.
Yes, Hispanics.
We have all the time in the world. And it's hard, from a patient point of view, to understand that maybe there is a limited amount of time that can be spent in the clinic. It just doesn't relate. It doesn't connect in terms of what the diaries of time to the health practitioners compared to the patient. I don't know how that's explained or kept in mind for different patients.
Well, it's especially hard for the patient to understand when they've been in the waiting room for a long time, and all of a sudden they get to see the doctor, and it's, oh, hi, bye.
They need equal time.
Yeah.
Decisions in medical treatment, I think we've been talking about it, how it can vary from culture to culture, where in some cultures, the elderly people are the ones that have the say. In other cultures, it's like the entire family is involved in the decision making. In other cultures, there's one member that makes the decisions. And understanding that can save you a lot of grief and time. The respect for authority and politeness. I think that sometimes that could be a deterrent if they don't understand that the doctor is there for them. They are kind of afraid of that figure, that authoritative figure. Some studies show that some patients don't want to take the time with the doctor because they are so busy. So they withhold information, particularly pain information. And that's why some of these voice-activated systems where they can call, the patient feels more comfortable talking to that phone call. If there's some automated systems, they use it for research purposes, and you call the patient and then ask a number of questions. The patients feel more comfortable talking to the phone because when they went to the doctor, they perceived that the doctor was really busy. And they were not telling a lot of the symptoms they had. It defeats the purpose. I think it happens based on what I read, for example, with the Hispanic woman, and how to address a patient by name, to do it with respect. For example, I'm Hispanic. In my culture, you say doña for a woman, for an older woman, and don for the older man, and that's respect. Like, you would say Miss or Mrs. or Mr. So it can, we need to know these things. The appropriateness of questions during the interview. Also, some people could be offended when you ask for sexually transmitted diseases, for example. If they have relations outside their marriage, they can be very offended. How much do they drink? Okay, I wanted to mention this because I thought this is culture. In Puerto Rico, this doctor and investigator Cornelius Rhodes spent some time doing research in the 1930s, and he was a very prominent physician And for some reason, it's kind of at the same time that the Tuskegee and syphilis study is going on, because that starts in 1932. In 1931, he says that he was in a party and he drank a lot. And when he got out, they had vandalized his car in San Juan, Puerto Rico. And he got really upset and he wrote a letter and talked about these Puerto Ricans and said that he was happy that he had transplanted cancer cells into some Puerto Ricans. And this is history in Puerto Rico. I mean, this is, if you ask my dad, he'll tell you, oh yes, I remember this. It was a big deal, and it's at the time that Pedro Albizu Campos was alive, and he was the one that started the Independent Party, where he wanted Puerto Rico to be an independent nation associated with the United States. And he went after this guy big time against Dr. Rhodes. But Dr. Rhodes was a prominent man, and he got to be the president of Memorial Sloan Kettering Cancer Center. And not only that, he initiated chemotherapy as a treatment for cancer patients. So he is a fabulous physician. And in the 2003, there was a number of people that complained because there was a very prestigious award under his name, and they felt that it wasn't appropriate because his letter was still going around, speaking, about Puerto Ricans and injecting cancer cells into Puerto Ricans. He accepted that he wrote this letter, but he said that he was drunk and that he really didn't transplant cancer cells into Puerto Ricans. But he accepted that he wrote the letter. And in 2003, the prize was removed, and it's no longer a prestigious award in his name. The AACR had that prize under his name. So Los Rayos Gamma is an interesting cultural effect to that. In the 1960s, this guy, Jacobo Morales, he's not only an actor, but he also makes movies, and he's Puerto Rican, and one of his movies won Academy Awards for foreign film. And he's, well known in my country. And he developed this character, Cornelio Rodas. He called it Dr. Cornelio Rodas. And he was a descendant of Dr. Rhodes. And they had this other guy that's really funny, Logroño. And he developed this character, Igor, that wore a fake hunch and made these guttural noises, and was always messing up the plans that Rodas had for exterminating Puerto Ricans. So, I saw this and I thought that I needed to bring it up because it's how culture perceive, something that happened and that impacts on building trust. Building trust is not only language and culture. It's building trust is important in healthcare. I think that the worst thing that we can think of is the Tuskegee syphilis experiment, where black men, sharecroppers from Alabama, were subjected to a period of observation without any treatment to see the natural course of syphilis. And when treatment became available, it was withheld, and it wasn't until 1970s, right, when this came out on the press to stop such research. And there's also other groups that had bad experiences, like American Indians, that the federal government gave them blankets infected with smallpox and exterminated a lot of them. And then the one that I see a lot is medication side effects, is iatrogenic. It's what we do. Patients stop taking their medication, and it's not that they don't want to, it's that they just can't tolerate the medications that we have prescribed. And part of this trust is accepting that there is a problem and that we need to work with that and come up with alternatives. I think what I found out most in the literature about building trust is to be transparent. Transparency. How do you do that in your practice? Building trust. I think you can build trust.
I think listening to the patient is the big thing.
That's the major.
Really
That's
care.
the number one complaint, that doctors don't listen. So you're pointing out something that is the number one complaint. The doctors didn't listen.
This goes a little bit what we did last month with disclosing of medical error. The legal part as well as the ethical part. When there's something done wrong that the patient may need to know. When it's disclosed, when it should be, always wrong.
Mm-hmm.
Or when is there a point when it shouldn't be disclosed and it was found out, obviously that has an issue with trust. But what if providing the right information to the patient? All the information. They may need to answering the questions completely comprehensive. Do they get that feeling like maybe all information is being given that they need? Why is that?
That's all he said? Alright, did you want me to turn from the right or turn from the left?
彼の方はもう準備ができてます。それでスタートがかかった時にカメラの方に振り向いて左から振り向いてがいいのか右から振り向いてがいいのかそのところはいつもやってみましょう。でもどっちだっていいんだよ。偉いんだから時間がないんだよ。おじさんだからもう早くちゃんとテンション上げてカメラ見てカメラ目線ゆっくりと、ね、パッションがカメラの目にはパッションだよ。分かった？
All right. Yeah, I thought it really shows what we're trying to say, that interpreter is keeping a lot to herself. And obviously, Bob Harris is feeling uncomfortable because something else is being said that he just doesn't get it, he doesn't understand it. That creates trust. And that was an example that was brought up about cultural competence. If you have a patient and you have a translator and the communication is not effective, then you lose trust. We already went over the definition. There is data to sustain or support that failure to use trained interpreters leads to higher hospital admission rates, increased use of testing, poorer patient understanding of the diagnosis and the treatment, and to misdiagnosis and improper treatment. No, it's this. The fact is that in our clinics, we don't have interpreter services many times. Now, if you know ahead of time that someone that doesn't speak the language is coming, you can make arrangements to have an interpreter. But as it is, we don't usually have trained interpreters in our clinic. And what we see a lot is that we get somebody that speaks the language from our own personnel, typically the secretary or somebody like that, and they are not trained in health sciences. And there are some suggestions about it's okay to use them, but there are certain rules that they need to be trained on. And one is to use the universal form of language, what we were talking about. When patients are communicating, to also bring up any kind of nonverbal that they can see, or any type of signs that you understand based on your culture. To refrain from assuming the role of interviewer. And it happened that on occasions the interpreter doesn't believe that the doctor should be asking this particular question, or the clinician involved. And it is important to ask that question. But the interpreter feels like, no, you shouldn't ask that. Or no, that's not happening. So they don't translate everything that is being said. So they need to understand that they cannot assume the role of the interviewer. They have to let the patient lead the discussion. They have to translate everything. They have to translate in a way that conveys the cultural framework. They have to meet the patient. It is recommended that they meet the patient before the encounter, and also meet with the doctor to work a plan prior to the encounter, and to seek continuing education so they get familiar with terminology. So you can use interpreters from your own staff, but they need to be aware of these rules. Okay. And we're going to have another video clip. This one is the patient that is an immigrant from Afghanistan, and he has the he was feeling chronic abdominal pain, so he went to his physician in his hometown, and it's a rural area, and he referred him to the big doctors in the city, and he was diagnosed gastric cancer. And what we're going to experience here is how the family is doing the interpretation, and one of his friends, of his close friends, and I think we see this very often in the clinic, and you have to be aware that when we are doing this, your message is not necessarily transmitted to the patient the way you intended. So they withhold some information that is crucial to his well-being.
Okay, so Mr. Kochi, 60-year-old fellow with a history of locally advanced gastric cancer. Surgery was September of 2000, had a partial gastrectomy. At that time you met with him, recommended chemo. He's eating more. His weight's down about 7 pounds since you saw him 3 months ago, although he says it's the weight loss in the last 2 weeks.
So he's after his spinach and chemotherapy?
No.
Let's take this in, yeah, let's see.
Okay.
What worries me is that the CT scan from March shows that there's a little bit more disease than there was even in January. So I'm worried that the cancer here is a little bit worse, even though he's fitting well.
Madam, she's more picking up her hours, you know, usually give me a letter breathing, maybe you do the shower to the assault, more didn't the affection, generally for the patient.
So just as when we talked last fall, I think that it is reasonable to try some chemotherapy, and my recommendation would be to try some chemotherapy to try to make these tumor nodules smaller in the abdomen. So it's always hard to give no percentages like show the picture. It's a very good question. The truth is that no one can guarantee the benefit. But I think that if we were successful in getting shrinkage of the disease with a relatively mild chemotherapy, we may feel well longer. And it's hard to put a number of months on that or a number of years. I think that our goal in medicine is to help you feel as well as you can feel until that day comes. So this family agreed to undergo the surgery. I don't actually know what the patient himself knew at the time of surgery, but nonetheless went through the gastrectomy. And at the conclusion of the procedure, which he fortunately tolerated well, was told that we got it all. We enter certain surgeons all the time. We got it all. But why didn't you go see my friend downstairs talking about chemotherapy?
Last issue is when there's a language issue. I do not operate on something that does not have an opportunity to talk to me. translate. Yeah, hospital translate.
Rather than
Not the family.
we get cut in that line. Rather than.
And that, you know you're in trouble when you give like a long paragraph. 2 words. You know, it's like, wait a minute. Are you telling what I said?
I don't know how much of it relied on his religion or his background or his sense of logic or sense of health or fear of chemotherapy, or how much may have been a miscommunication that maybe you would have accepted chemotherapy had it been more convincing. Why don't you just relax there? I'm going to lift your leg. I want you to tell me if this causes any pain. Very flexible. Much more flexible than I am. Okay, let me help this stuff. Well, I'm sorry you're having discomfort here. I don't know exactly what's causing that discomfort, though it always concerns me that it could be a tumor. We know that the cancer or the tumor is in this vicinity, is in this area of the body.
So he still has it?
So he still has it. And it may very well be that the cancer is contributing to that pain, even the pain in the back.
So you're basically telling me my dad still has the cancer? Because I know when I talk to Bandar,
I think he's always had cancer. I don't think I've always felt that he's had this cancer. Why don't you just have a seat down here? We can talk a little bit more about this. So I know this is the first time we've met, so you have not been able to participate in some of the other conversations. When I first met your father, it was more a question of whether he would agree to try some chemotherapy to try to control the growth of the cancer in those lymph nodes. And he chose not to have chemotherapy. We talked about chemotherapy options.
Yeah. When you were like giving him the options, were there was a translator or just my sisters?
No, I don't remember. I'm sorry. I honestly don't remember.
When I asked my dad why he refused chemotherapy, he told me because there was one that they were going to put a pipe through his arm.
Yes. So one of the drugs we give as a continuous infusion.
Yeah.
That is, we put a long catheter in the arm, and then we hook that catheter up to a small pump, and then you carry around the pump, and the pump slowly drips in the chemotherapy 24 hours a day. Curiously, even though that sounds horrible, it actually turns out that the chemotherapy is easier that way. So one sad confession I have to make to you for the first time, but I've always spoken with him and other family members, is that we don't have any treatments that will cure this disease.
So
his disease is incurable.
His is incurable.
Incurable, which means that I don't have a drug that will make it go away forever.
I know it doesn't, but will it slow down? Then
well, that's what we hope.
If he can live 1 minute longer for us, it means a lot to me. I know he's like a religious person. He accepts his faith, and I believe if there's a disease, there has to be something to either kill it or slow it down. And I don't want to lose my dad just because he decided not to. I think there was no translator at that minute. I mean, like right now.
That was the first visit where I met his daughter, who was a little bit outraged that we had not offered him treatment before. Of course, we had offered him treatment, but he had chosen not to receive treatment.
حتى ما بختاروا دوري سكتشيكا بيتشكاهي يا تابلت يا كبسولي زي عفوا استعمالهم وندير زنادة
When I asked Dr. Fisher, he says, oh, well, I did tell your dad, but your dad never agreed to it. And when I asked my dad said, he never told me. So I don't know who to believe and what to believe. Translated them sort of with the butch to butch the bara. Grandmother Shatan, really, I'm not a film that you do, and then you will not even my and I like Nadisa and do it. I don't know. またちゃんと間か例えばマウンテンスで気持ちを見てやられたしようか。نوع التعب سيد الشغلات bisa aku banyak cerita di kakak tu pergi bisa ada terbilik tak perlu cara terbilik apa itu cuma boleh ada tu pada lalu mana ya mana itu mana sekolah kamu nama tu betul sekolah itu sebab ni indah mungkin masih makin ada terus But when I look at what Bishop told me, like, well, I always offered chemotherapy to your dad, but yeah, you would keep on offering the same thing over and over, and my dad would keep on refusing that. So now, right now, I actually understand my dad. Yep. I think how my sister explained it to him, every time Fisher was saying chemotherapy, my dad was like, oh, the pump. Before praying, you have to be clean. You wash your hands, your arms, your face, your feet. You cannot allow yourself to bleed, or you cannot have something injected to your body. So that's why my dad couldn't do it, because he couldn't pray.
SFA.
Yes, can you hear me?
Yes. What can you describe the problem of communication that you saw in the video?
Can you describe the problem with the miscommunication, or what things you saw that were problems in miscommunication?
Well, our table discussed certainly the cultural issues. Doctor initially probably did not explore some of the religious beliefs and didn't realize that that was certainly impeding on the decision to use the pump.
They didn't maybe dig down deep enough. They understood they had a spiritual concern, but the physician might not have asked enough questions to realize maybe why they didn't, maybe because he probably didn't ever understand it, because he didn't want to he couldn't take the pump into that thing. I'm going to jump back here to this next table. Call somebody.
Well, we thought the communication also had to do with the acculturation of the daughter. She seemed to be more Americanized, and even said, well, you know, he's a religious man. So her views were different than her father's views, and we thought that might have inhibited some of the communication.
How about back here? One more time here, Tony.
Okay, Mark. Doing great.
We thought was that we felt that the doctor was doing a good job as far as, you know, talking with the gentleman, and that he actually mentioned chemotherapy at both of his you know, consultations. But if he had gone farther into the chemotherapy and what that entailed, and it wasn't until the daughter came that it came out that, okay, he probably did know a little bit about it, and, you know,
Right.
because the daughter was obviously upset, and the father saw that.
So maybe you could bring in more family at a later time, getting all the points of concern. Right, great.
Okay.
Very good, Mark. I think you should have your own show. Excellent. All right. Okay, maybe, let's get
Terry,
Terry
Lamar, can you tell us a little bit about how you see the role of the doctor in this?
The doctor, I think he probably did the best that he could do with what he had. However, what he had wasn't good enough because apparently the gentleman, I think, misunderstood some of the things that he was told. And then some of the things he was probably just in denial about. But the doctor has to make sure that he understands it. If he doesn't understand it, then he bring in the translator. And they had the daughter there. But remember, when we talk about generations also, what they believe then and what we believe now is a problem also when we talk about barriers of communication and understanding. Because even though the gentleman may have understood what the doctor told him, and then you bring in his daughter, I mean, that right there can pose some more barriers because she's not going to tell her father everything to the satisfaction of him knowing everything because she's going to try to protect him, and then the gentleman is not going to share everything with his daughter because he's the father. So I think the doctor, he should have gotten clues that he needs additional help in conveying the information.
Good point. What's the other group?
Victoria College.
Victoria. Okay, Victoria College. Can you describe the role of the interpreter in all of this, in this communication?
The role of the interpreter should have been, would be to convey the exact meaning of the conversation between the two individuals, the doctor and the patient. But we were missing that because the interpreters were putting their own twist on things and not providing the doctor with the background cultural concepts of the information.
And what did he do to the patient? What did he tell the patient? Did he ever told the patient, remember when they were looking at the x-rays with the physician? The interpreter tells him there is a darkness in this x-ray. He doesn't even...
Right, but he... It wasn't an objective interpreter was the problem.
Exactly.
It wasn't a real interpreter, it was his friend. And in any of these situations, as we were talking, to have, the friend would be fine to have there for later, and so would the daughter. That'd be great. But you needed an objective, real interpreter to get the entire message clearly to the patient.
Definitely the interpreter was protecting the patient from this negative information that needed to be conveyed. All right, very good. So what happens when the daughter comes in? This group.
The daughter obviously was kind of bringing her own baggage in with her, and that she was feeling guilty that she wasn't there from the very beginning. She'd allowed his friend and then the other daughters to kind of be with Dad and do the translating in that manner. So there's also some emotional issues there that were going on as well. We also brought up the fact that, which some of the others have as well, that she was a younger generation versus the older generation, which came out immensely when she's like, I want my dad to be here forever, even if it's for one more minute. And he's religious, she says, so basically it wasn't bothering him if he was going to die or not.
Mm-hmm. He was resigned to his fate.
Well, it was predetermined. His fate was predetermined.
Yes.
He had so many days, which was counter to what the daughter.
So what can be done to prevent this from happening?
Well, some of the other groups have mentioned this. Obviously, a trained interpreter would have been helpful in this situation. And we didn't really talk about this, but I think that all of us, if we're treating patients from different cultures, from different countries, it would be good to learn something about that, about their religion. We talked about the family needs empowerment, so that if there are family members, that they feel empowered to ask questions. So I think that this daughter that came in later didn't hesitate to ask questions, but what happened with the ones that were there earlier? Why did they not feel like they could ask those same questions?
Or were they in the role of the interpreter, that they felt they needed to protect the father from this information, and they were withholding the information the doctor was telling them. So all these things were happening here. Let's switch to the slides. What we were seeing in part, communication styles that you all mentioned. The daughter has a more aggressive communication style. The father is more resigned to his fate. Then the poor outcomes as a result of this cultural encounter and miscommunication, the lack of understanding that the religious belief wouldn't allow him to have a chemotherapy pump. Then he wouldn't be able to pray, and that was important to him. The family that and friend that protects him and doesn't want to tell him certain things. And I added something here that we need to be aware of. One of the most common interpreters in the clinic is going to be family members and friends. Either family members or friends can breach confidentiality. So you have to be aware, and the patient needs to be aware that this person now has his personal health information. That is not only the physician and the clinical members that know his personal health information. Now you have an external source. And this is something that patient needs to be aware of from the beginning. I think it's important for us to let them know that. So in essence, the best interpreter is not necessarily a family member or a friend.
Doctor, we had one thought in addition, because I've heard about introducing a translator at all of our facilities, but I think it also really shows the importance of why we need to recruit and retain a multicultural diverse workforce in our facilities, so that we have doctors and physicians from all walks of life and all different cultures to help address these issues directly.
You have a really good point. You're bringing up a really good point. The best combination would be someone that has the background in science to understand the illness, the treatment, and the prognosis, and that can communicate in the same language as the patient. That would be the ideal communication setting.
The other thing, when you talk about the breach of confidentiality and some of those issues, sometimes we have children that come as the interpreter too. Especially in the summer when kids are out of school. I've seen people bring in maybe middle school age children, maybe high school children. And how much of your information do you want your children to be privy to?
Right. And that interferes tremendously with the effectiveness of that physician-patient communication. You know that you have to look at the patient, even if you have an interpreter, when you're talking, to maintain and increase the effectiveness of that communication. But when you have that fear someone else is in the room, the patient is unlikely to tell you things that he would have otherwise. So it's all these things that affect the outcome of the physician-patient visit.
I think that's one thing, we alluded to what was the patient's, or what was the doctor's role, what was the interpreter's role, what about the patient's role? I think they need to be upfront as well, whether they say, okay, I can't ask you this in front of this interpreter here, or some way to communicate that, or the doctor start out by asking, or we as healthcare professionals, where are you at with this? Are you comfortable? If you have further questions,
And it's going to be hard in this context where he didn't speak the same language. You just need somebody there.
Even as his interpreter was saying, you're going to be on chemotherapy, you're going to be on a pump, and what I interpreted the patient's first concern was, oh, am I going to be tired all the time? Yeah, I mean, but who isn't, The other fact is, he didn't bring up the fact that, well, it's because of my religion, or what does this mean, or to be open that way too.
Mm-hmm. Because his communication style was more
he saw
resigned.
But we don't know that he didn't with one of the interpreters. We counted at least 4 throughout his history, 4 different interpreters. So we don't know what he said.
Yes.
He might have.
In this culture, the father decision is more important. The man decision is more important.
He was like the
Because
elder.
his interpretation of the information is more important.
Mm-hmm. And now he's kind of challenged by his daughter, and it gets to him that his daughter is now so concerned. So so the role of the interpreter is a connector between the patient and the provider, and it's important that this interpreter understands that he needs to tell everything that the doctor is telling, so that there's not this kind of gap. And the same on the other at the other end. Whatever the patient is saying needs to be conveyed to the doctor. Because maybe, like you guys are pointing out, maybe the patient did say that it was important for him, but the doctor never knew it. So it's important that that information is conveyed back and forth. And if you have people in the clinic that are doing the translation, they need to know that. They need to know that they have to tell everything that the patient is saying, everything that the doctor is saying. Don't play the role of the interviewer, right? So it's...
In terms of, real quick, I was just wondering, I was looking at it as, is it just an unfortunate case, for the patient, that it turned out with this miscommunication and lack of communication is there? Does it go beyond that in terms of any legal issue? Is there any legal issues or any recourse? Is there anything the family can do for this lack of communication, wherever the mistake was, if there wasn't? How's that interpreted? And is it just, well, he just didn't get the best care he could?
And perhaps what you're saying is families need to also be concerned if they don't speak the language of the country to request an interpreter be present.
Where's the responsibility?
Yeah, the responsibility is shared by the patient.
Yeah, where do you define neglect?
Right.
Who's being,
right.
Negligent, basically?
All good intentions.
How many times you talk to people from a foreign country that are here and they're like, they really no clue what you're saying, and you're going, oh, okay, they understand, they're nodding their head.
But is that really any different from someone who speaks the same language that just doesn't understand what the doctor's telling them?
That's a different circumstance, but yeah, it may not, but I think it is.
And also there's that bias because the physician who was the interpreter in the first scene for the patient he is also of the same religion, and so he might have been looking out more for the patient as far as how he would be able to pray.
Very good. Yeah.
I don't know if it's true or not, but I thought we had been told that if you do not have a trained interpreter, you can be held liable for being sued, or I mean, you just can't do that. But I don't know if that's true or not.
Tony, we have someone who wants to speak.
Sure, go for it.
Don't you think that it's the responsibility of the hospital and the quality of care that they're providing on whether or not a translator should be provided? A professional translator?
The rules differ from state to state. So in some states it is mandatory to have an interpreter, trained interpreter present, but it varies from state to state.
Where does ours say here?
Well, because this man did not receive proper translation, it cost him his life. It probably cost him 6 months of his life because of the error in translation.
That's a good point.
The question is?
Now, there are different types of technologies available for us at the clinical level that you can access translators, for example, over the phone. However, those services are expensive, particularly over the phone. They charge by minute. The ideal would be that at the time the patient is making the appointment, he is asked if he needs some kind of translation services, so you can schedule it.
And I also believe, you can also kind of play the devil's advocate and the flip side of that and think, well, if I'm a patient and I know that I'm in a foreign country that everyone doesn't speak my language, and if I'm dealing with something like cancer, I'm going to make dadgum sure that I have somebody there that speaks my language. And I know that this person had his friend, but I might even seek a medical doctor that speaks the same language I do. Which, so you kind of play both sides of that.
But how many Afghan doctors are available? Might not be possible to have somebody that speaks the same language available, But yes, I do get your point, and it's clear to me that the patient has responsibilities as well.
Well, two things. One, in some of the cultures that we deal with, they don't see that it's their responsibility or put forward because the doctor is the doctor, and it might be forward or some reason to demand certain rights. Mm-hmm. The other thing is we're working a project right now with emergency medical dispatch 911, and that's the difference between a trained response to provide medical instructions till EMS gets there versus what Texas law only requires now is a dispatcher to hold them on the call until EMS gets there, but does not give medical instructions on CPR or choking or other things that they can possibly do to sustain. Right now, AT&T interpretive services over the phone can be used for Spanish speaking, Chinese, Vietnamese, some other, and as you said, they're expensive. But the limit for that is just the basic things that a dispatcher says. If we get this turned around to where more pre-arrival medical instructions can be given, those services won't be adequate to give some of the language that we need to give, possibly. So even for medical, some of the technologies may not be adequate for what we need to do interpretive services when someone comes in to say the emergency room, even if we had the money to call, say, AT&T Interpretive Services and ask for a translation.
Mm-hmm. I think it's also, then we got to go into the next portion, which is looking at the professional team and how this might actually relate in terms of how a professional team being called on can provide a little bit of clarity.
Yeah, I think we're giving more importance to interprofessional teamwork now. We should have done it for a long time, but at least we are now. And the reason is because the outcome is better for the patient when you have a multidisciplinary professional group. One thing that we need to each other understand is the role of each person in the team, the scope of practice of each member of the team, and maintain the communication. If you want, you know, if I need a therapist to do some intervention that is innovative, communicate with that person. Understand if she can do that. Understand if she needs more training to do that. Because it helps everyone in the team to understand each other's roles and to move forward. Also, look at barriers and mechanisms that help the team work better. As you know, sometimes I am seeing the patient and the note that the physical therapist wrote is not available. What things can we do to have our medical records integrated? And also the communication between practitioners, either physicians or other clinical personnel. The participation. There has to be good, efficient communication. Everyone in the team needs to participate in the care. Everyone brings something to the care. Education materials. The receptionist, like we are talking now, look at the role of the receptionist in making this appointment and asking questions like differences in language that we can prepare beforehand for this encounter. I don't know your experience so far in interprofessional teams. Would anyone like to comment about their experience in interprofessional teams? I think that we don't have too many. One that I always hear about is the geriatric team. Unfortunately, I know that it has changed over the years, but some places have teams and some places they don't work in teams.
I think one thing that has helped is the online charting. So at least it's a little bit easier where you can look up records and kind of see what's been going on amongst doctors, amongst nurses to doctors, and those types of things. That way has really helped a lot. A lot of times patients will say, I'm on the phone with them, well, it's in my record. Well, thank goodness now it is. If I'm sitting in front of my computer, because I can pretty much have some idea of what they might be talking about.
That's true. The electronic medical record has been very helpful in alleviating this problem.
Well, I do work up on the geriatric unit, so we do have daily team interdisciplinary rounds. And I also work in other areas of the hospital, and it does make a big difference because that 5 minutes you're able to talk around a table about every patient that you're seeing, and everyone has a say in that patient. You get different perspectives from different disciplines, seeing that patient in different situations, and so the end result is you get a much broader picture of what that patient is saying, what they're doing, what their concerns are, what their options are. Different people have different interactions with family members, so you just get a much more comprehensive picture, and your quality of care improves because of that. And all it takes is just a few minutes. And when you don't have that, that communication hardly ever happens. And so you're having to figure out all the blanks that are in just your small picture of what you see with that patient. And it's much more difficult.
It is. The communication in a team flows easier than when the team is not integrated. Also, working in interprofessional teams is going to help the innovation, bringing innovative treatments, innovative diagnostic techniques, the communication in that team, so that, as you know, errors are lower if there is good communication among the team members. What I forgot, you remember. What I remember, you forgot. So we give feedback to each other for a better outcome. And also, it provides for leadership, for development of leadership. And like we are pointing out, in overcoming the barriers. Any questions so far? Or any comments? SFA, any comments? Or questions?
We have one.
Okay.
I just have one comment as a translator at times for like Adult Protective Services. I had to undergo some testing to do that, but I just wanted to explain, sometimes people don't understand the process of translating, that it is difficult and it does take extra time, and I think that doctors sometimes, their time is precious as everybody else's is, but it's going to take double the time when you've got a translator, and you have to wait after you've said something, the translator has to translate that, then you have to wait to hear what that person, and it is a process. It's not something that is easy, and I don't think that people realize that it is difficult. It's a difficult process. And it's even more difficult if you don't have that scientific background, even though a lot of us who are certified are probably educated enough, but we still don't know all the language or the terminology or understand the medical process. So I do want, from a translator's perspective, to indicate that it is a process, and there's a lot, just as an advocate for translators, that everybody has to be patient. It does take time.
That's very good. Yeah, very good point. So as soon as a patient comes to the clinic, the physician has to understand this is going to take me longer. And that's just the way it is. That's a very good point. Well, to wrap it up, I think that we've learned how culture can affect our delivery of health care, that we have to build in culture so patients can understand in their own cultural context the message, the illness process, and the treatments available, and the physician to take, and the providers to take the extra time necessary to utilize interpreting services, understanding the limitations for better outcomes, and to use your team, use your interprofessional team to back you up, to complement the treatment that is needed for this patient. So,
Any other comments?
okay.
All right, well,
Thank you very much.
Thank you, Doc.